Hello and welcome to the Safety and Quality Education Program podcast. Developed by Metro North Health Safety and Quality in partnership with the Clinical Skills Development Service. Metro North Health acknowledges the traditional custodians of the land upon we live, work and walk, and pay our respects to elders past, present and emerging. The Safety and Quality Education Program has been designed with a focus on patient safety improvement. Each episode will explore ideas and stories in making our care delivery safer for our patients through the implementation of short notice accreditation. Our host is Dr. Mia McLanders, who is the Manager of Research at Clinical Skills Development Service. Mia is an applied researcher with a background in human factors and cognitive psychology. Joining Mia on this episode from Metro North Health is Alanna Geary and Kevin Clark. Alanna Geary is the Executive Director of the Office of Chief Nursing and Midwifery. Alanna has a professional oversight of approximately 9,000 nurses and midwives in Australia's largest health service. Kevin Clark is a Nursing Director of Internal Medicine Services. Over 28 years of experience in healthcare with strong technical background with focus in strategy and clinical operations. He's had experience in large projects in process optimization and implementing service improvements to support excellence in patient care. In this episode, we explore recognizing and responding to acute deterioration and how clinicians can be supportive to do this.
So, Kevin, I'm going to put you on the spot for this one and ask you for what does this standard mean for you and for your family in terms of when you're turning up to hospital, how do you think this standard's going to what it's going to mean for the care of yourself and your family members?
Yeah. What it means for me, knowing, I guess, about recognising and responding to deteriorating patients and the standard and the elements to it, is that if myself or a family member presented to hospital, there is a suite of tools and processes that look at patients' observations, not just their physiological observations, but mental state, cognitive state, that help provide parameters, I guess, on which we assess, and then actions can be taken. Equally, if I was unwell or deteriorating, that there is a escalation process in place, a known, so we have our MEC call system, or if the treating team was on the ward at the time, they would be called to support my clinical care or my loved one's clinical care. The other part about the standard, I guess, it ties into the Ryan's rules processes that we have. So therefore, if there was other questions that I might have around, I feel other information hasn't been taken into consideration, where I feel my family member's deteriorating, the observations might be okay, but there's other factors that I'm concerned about, like their cognition has changed. Mum can't remember where she is, and she's a very good historian, but this admission, there's a process of sort of saying, look, I'd ask that for a clinical review. So I think there's lots of aspects to recognising and responding to deteriorating patient that assures me as a clinician, but equally as potentially having a loved one in hospital, that there's really good systems, processes, and our staff are well trained to recognise early deterioration to allow quick and prompt action, I guess.
Mm. Yep. And there's been an increased emphasis lately on the mental state deterioration escalation specifically within our patient monitoring. Can you talk a little bit more about that?
Look, I can talk about it from an acute medical perspective, because often when people come into hospital, it's very easy to focus on what the primary concern of their admission would be, but also we need to be considerate of the patient's other care needs. So those other care needs might be, I guess, that there is, based on their other factors of life, some depression, some anxiety, some other sort of psychosocial factors of concerns for their son or daughter who might be unwell at the same time. So I feel within the acute mental health deterioration, it's really important you are right, it's great to have that as part of, I guess, our observations now and more awareness of acute mental health deterioration, because often it does tie with physiological deterioration, so such as things like an infection or drug toxicity or sort of drugs that may be contributing to it. So I think the beauty of more awareness of mental state assessment is helping us, I guess, provide a more holistic assessment for the patient, and that's something I think healthcare clinicians within hospitals do particularly well. So I think it's providing additional information to us that helps us deliver the plan of care.
I think one of the most important things with this standard, certainly when it comes to cognition, is engaging with the family, because what might seem normal to us, because we've only met Mrs. Smith this way, is very abnormal for the family. So being able to say to the family, is this how your mum is normally? And if they say yes, that's fine. You can actually park that. But if they say no, she's a bit off, she's not normally this down in the dumps, or she's saying some very odd things, or, I don't have a cat called Fred, those sorts of things, then we probably really need to think about what is making Mrs. Smith go off. And as Kevin said, it can be an infection, especially in the elderly. An infection can manifest in very different ways than what it does in a young person. It could be the drugs that we're taking. It could be that the drugs that this person is taking are contraindicated for the condition that they've got. There are a whole host of things that can actually lead to deterioration. And deterioration isn't just about the patient suddenly goes flat and you have to call a cardiac arrest or call a MET team. Deterioration can just be a little bit of a change in cognition. It can be a little bit of a decline in the way they look after themselves. Somebody who comes in who's very well dressed and obviously caring for themselves comes in dishevelled and really not interested. There's something going on. So it's really important that we understand that deterioration is not necessarily just prior to the patient passing away. It's often a slow decline.
So what's the best way that we can support patients and their families as an active line of defence in recognising and responding to deterioration?
So I think probably we've spoken today a little bit about comprehensive care. So I think appropriate assessment. And I think the comprehensive care standard is really tied up with all of our standards. So actually have good understanding of the patient's baseline, what they're normally like, is a really good place to start, because then you will notice deteriorating symptoms and signs. If you don't have a baseline, you can't possibly understand what that looks like. So I think, once again, communication not only with the patient but also the family, communication with the healthcare providers, often getting a history from the GP or another specialist who's referred them, if they've been seeing a nurse in the community, whether it's domiciliary care or aged care facilities, we really need to get that really robust history so that we know what the patient is normally like, and then you can make an assessment based on that.
Yeah, Alanna, you've summarised it perfectly. Yeah, talking to the patients and families, understanding what the baseline is, listening to concerns. If the son or daughter comes to visit, is there anything that's concerning you, I guess, or is there anything else you think we may need to know that supports your mum or dad's care, and using that as an opportunity. The prompts that they provide, use that as an opportunity to provide interventions. The big part about recognising and responding for me is always to be engaging and not to be dismissive, I guess. I think the concerns come, or things may not go as well as we would like them to, when it's very easy at times to maybe, not purposely, but possibly not listen as intently to patients in what they're saying, or the relatives, where there may be just slight concerns, which might seem incidental. You're coming in with X and then they're talking about something related to a medication. You go, well, that's got nothing to do with, your leg infection or your urine infection but it's actually important information that we should collect. If there's any concerns that the patient expresses and or the relatives, that's as important as the physiological observations for me. And in some ways, sometimes more important, because as Alanna said, it's often that trajectory that we only see what's in front of us at the time or during that admission, but it's what's been going on prior to admission that's also important. And that's the beauty of the processes we have, having them, I guess, looked at across.
I can give you a little bit of an example, and I'm going to draw on my family again, but my father-in-law was admitted after a fall, came down a set of stairs, had a nasty head injury, but was improving slowly. He ended up passing away a few months later, but that's what happens. He had probably about 20 or 30 years ago, he'd been a smoker and he'd been a big drinker, and he'd put a cigarette in his mouth the wrong way, and he'd given himself a nasty burn, which just kept turning into an ulcerative. So he had iterations of plastic surgery. This is in the 60s. And basically they'd use the inside of his lip and sort of hold it down like that. Now, when he had his teeth in, you could notice nothing different than what you and I, just a normal lip. But when his teeth were out, it looked as if he'd had a stroke. So he comes into hospital, and nobody thought that this man might like his teeth. And I used to get a little bit distressed because I'd go up to visit him, and this is a man for 80 years of his life. He'd got up every morning, had a shower, cleaned his teeth, put his teeth in, put his shirt and his pants on. And I'd go up to visit him, and he'd be sitting, and this isn't in one of our facilities, so nobody need to feel too embarrassed. I'd go up to see him, and he would be sitting on a vinyl chair with a gown on, so his backside was sticking to the vinyl. No one had thought to put his teeth in. No one, all he wanted was a hot cup of tea. And although his cognitive state was declining, he'd been a huge football fan. So you could have put any game of football for anywhere between now and 1920, and he would have watched it because it all would have been new and exciting, and he would have loved it. No one thought we'd organised television for him. The moment I gave him a cup of tea, I put his pajamas on him, I put his teeth in his mouth, and a cup of tea, he was fine. But what was interesting is the medical staff came around when his teeth weren't in and started investigating him for a CVA, for a stroke. He hadn't had a stroke. He'd had no teeth. Put his teeth in and his lips came up. That was how the plastic surgery had worked and formed for him. So if they'd listened to the family, if they'd talked to the family, if they'd treated this man, I believe, with the respect that he was due, all he wanted was what was normal to him. And he was not aggressive. And at one stage, they actually had him tied into the chair so he wouldn't get up from the chair. He didn't need restraining. Once he had his pants on and his bum wasn't sticking to the seat, he was absolutely fine.
Yeah.
So I think, he was deteriorating, but deteriorating because of what was happening to him, not because there was anything going on. But I think that deteriorating patients, we really need to look at what's normal for them and then work back from there. And usually it's a puzzle, and it all fits together nicely when you actually think about where they were, what they've got now, what's in between, talk to the family, work out the best way to do it. And, we speak about nurses and sixth sense, and I'm happy to bring that up. Kevin and I have been nursing for a very long time, and we're not going to divulge our age too much, but, the reality is most of us can walk, that have been nursing for a while, can walk up and see that a patient has declined, especially if the patient's been with you for a little while, can see that they've declined and something's going on. Now, there might not be anything that you can actually assess at that point in time. The observations might be normal, oxygen saturations are normal, but you just have a sixth sense that something's going on. Now, that comes from years of practice. So I didn't have that sixth sense when I was a new graduate. And I think sometimes our graduates get a little bit nervous because they don't have that ability to assess quickly. That will come. Trust me, 10 or 15 years down the track, they will be as good as I was when I was working clinically, or as good as Kevin. It just takes time and practice, but knowing what is normal for that patient, not as what is normal for everybody, because everybody's so different. Knowing what's normal for that patient will give you a really good idea about what's not normal.
Yep. No, to build upon what Alanna's described, the beauty, I guess, of the standard for me and the elements to recognising and responding to clinical deterioration is we have great tools and education for our staff around patient observation. I guess a lot of people call them patient observation. But within that, what is fundamental to patient observation is engagement, listening and understanding to the patient. So as you're doing a blood pressure, as you're taking a pulse, as you're doing a SATS monitor, etc., a pulse oximeter and saturations, is you're talking to the patient, I guess, what is normal for you, how are you feeling today, are you feeling better than when you first came in, using all of that information to help gather the assessment for the patient. So if there were concerns of clinical deterioration, all of that is complementary information to providing an escalation to the treating medical team as part of a handover process or a situation, background assessment and recommendation. Those things, I know, talking to medical colleagues, that's the important nuances that help them respond with sense of urgency when not only someone's giving you the physiological parameters to something, but they're highlighting, look, the son or the daughter or the patient's expressing, this is different. They're feeling different. The symptoms are more frequent. this dizziness is not this is new, or the other symptoms they might have. So I think recognising responding to deteriorating patient is we have good systems and processes, trust your education and knowledge, but equally always listen to the patient, gather information as you're doing those assessments and observations, and relay that to your colleagues where you believe escalation is required and further treatment.
And what supports do we have in place for junior clinicians, Kevin, to help with that escalation during those terrifying times, nights and weekends specifically?
Yeah, I think we have the MET call system. So we have medical emergency teams where we have our systems where we can trigger those. Mm-hmm. Always that's done, I guess, you're utilising the team that's with you at the time. For nurses, there's often a shift coordinator that you're talking to, you're engaging with your colleagues, but we have those MET teams that are called to help assess and manage the patients with the team. So I think we have very good systems in place with our MET teams. And the beauty also, I guess the other part that we have is we use our information trended over time from our MET calls within wards or environments or patient groups to help look at trends or themes and help then improve our care processes that we're delivering, I guess, as well. So, for example, in elderly patients, we know from the data that a lot of people with an infection may not have a high temperature like a young adult might, but they might actually be hypothermic, so have a lower temperature. But that's actually sometimes a sign of an infection in an elderly patient because of how the hypothalamus and your response to things. So it's actually that knowledge, conveying that, but also not dismissing things, because often it's like, oh, well, your temperature's a bit low, that's okay, but actually just having that knowledge, utilising the team around you, looking at the trend over time, how did that patient come in, but equally responding. So I think we've come a long way, I think, in helping better recognise people with deterioration and also managing that.
That kind of ties into what you were saying before, Alanna, about nurse concern being a predictor of clinical deterioration. But it's interesting because you kind of describe it as a sixth sense. But how can we, do you think, best leverage and capture that? How do we, let me just try that again. Yeah, so with clinician concern and worry, how can we best support clinicians to be empowered to act on those hunches?
What everybody needs to realise is you're never on your own. Mm. There's always somebody around. And we work in, the biggest health service in the country, and we've got some amazing things happening in all of our facilities and directorates. And there's always somebody that you can escalate to. So if you're unclear, my strong advice is just to escalate. Even if it doesn't become anything, it doesn't matter. Trust your judgment, seek some advice. If it doesn't end up being a problem, that's fantastic. And if it does, well, at least you've escalated to somebody and somebody's there to help you. It is so important that we have the support of each other. We have to have each other's back. We're all here for the same reason, and that's to care for patients. But we're also here to, look after our careers. Nobody wants to be in front of a registration board because they didn't do the right thing. And most of us don't try and do the wrong thing. So I think it's important that we use each other and we use each other's skills, because even somebody who's been out just 6 months longer than you have may have actually encountered a similar experience previously. So they will actually have some knowledge that you don't. Bouncing some ideas off each other. What do you think? What do you think we should do? Should we ring the ward call? Should we ring the registrar? Do we need to call the consultant in? There is always somebody who's got that little bit more knowledge than you have, all the way up the line. So, at the end of the day, we can ring just about anybody to get the help that we require.
Mm. Kevin, have you had any experiences yourself from when you were nursing that where you've had to trust your judgment and make difficult decisions and in response to deterioration that you recognised happening?
Yeah, no, definitely. I think that happens on a daily basis for all staff clinically, I guess. Yeah. Even yesterday I was just doing something in one of the wards and a patient had what was believed to be a vasovagal episode, but basically was unresponsive in the chair with a pulse, I guess. So sort of the immediate response. But it was good that there was sort of that early recognition of that, utilisation, harnessing the team, looking at the different causative factors that might be in place based on the patient's history. So I think undoubtedly we call upon those skills and the knowledge we have. And equally, it's, I guess, knowing your patients well is really key. This ties into the clinical handover. And sort of from shift to shift, really getting to know your patients, equally the part of listening to your patients, making the time to listen and understand. So therefore, if there was deterioration during the shift, you know what other things you might consider. So it mightn't just be what's recorded on the observations, but it might be a blood glucose level. It might be that they haven't been drinking enough this shift. So maybe there might be some hydration factors that might be influencing the blood pressure. As you stated before, with mental state or fluctuating cognition, they are all important signs of something's not right. And as Alanna said, we have very good systems. We have very good collegial support to help support patients' care, and people should, where appropriate and early, seek that support of their colleagues using the processes we have, particularly, I guess, the METCALL system that we have.
Alanna, what are the accreditors looking for when it comes to this standard?
Collegiality, multidisciplinary teams, good communication, escalation at the appropriate times, excellent documentation, because it's hard to assess deterioration if you haven't documented appropriately. So making sure that you not only do it in a timely fashion, but it's actually accurate. It's very easy to get distracted, so make sure that you document at the time that you actually do the observations. It's too hard to come back and say, oh, remember what Mr. Clark's blood pressure was, because you won't in 15 minutes. You've got too many other million things going through your mind. So good documentation, making sure that you escalate appropriately, communicate, work with your team, talk to others, listen to your patient, listen to the patient's family. There's a whole host, there's a million things that the accreditors could ask, but the accreditors will want to know that you feel supported in the event that you need to escalate. I think that's probably most important. So if I can talk to team leaders and nursing directors and consultant physicians, my biggest advice would be know that your teams understand the escalation processes and that they actually follow through with them, because I think that's what the accreditors will be looking for. There's no expectation that you as an individual are going to be able to manage a complete emergency on your own. You can't. But how does the team respond to the deteriorating patient that's lying in front of them? And the other thing too is we've got, there'll be different pathways depending on where you're working. The pathway in the emergency department will be very different to in an acute care environment in a ward or in intensive care. And once again, we have aged care or rehabilitation type care and subacute care in Metro North, and the assessment skills that are needed there are just outstanding. I often say to graduates who get the opportunity to go to aged care, absolutely take it, because the assessment skills that you will learn in those subacute type areas are probably far greater than what you learn in ICU. There's no ICUs, there's no machines that go ping in aged care. So, I think communication, documentation, appropriate escalation, working with your teams, they're all the important things.
Yeah, very good. And Kevin, when it comes to the processes that we have in place to help support recognising and response to deterioration, what is it? Can you talk a little bit about that? Like, what do we say? Because I think you mentioned earlier about with the neurological observation forms, we've got a lot of different tools and things in place to help support that recognition and response.
Yes. So I guess the QADS is sort of the basis, I guess, of what everyone would know, I guess, that we use to capture our observations, I guess, and the prompting, I guess, of the frequency of those is often is driven by the care plan and the initial assessment and the treating team and guidance there. But as you say, there's a lot of other complementary tools that we have, whether it be fluid and hydration status, bowel regimes or bowel observations, cognitive or delirium assessments. So I guess there's a range of things we have, but the most common, I guess, we're using every day is the QADS, and within the QADS, I guess it has a range. It helps us trend observations over time. It helps you recognise deterioration early and allows a point of escalation. Equally, it allows for documentation of where there's accepted variance in certain physiological parameters that the treating team have agreed to, that allows, I guess, actions to be put in place. So I think, the QADS is probably the most common that we would people would be aware of. And I think what I'd encourage people to do prior to accreditation is look at opportunities that have been identified through clinical audit within the clinical weekly audits that we do, and observations are part of that observations are done as per the frequency. Any deterioration that's noted was escalated and there's documented evidence of that. So probably just being aware of, I guess, what the audits have shown for their ward, What have we learnt from deterioration? What things have we put in place? And particularly for me, I guess, a lot of good multidisciplinary teams, what they do is where patients may have multiple MET calls or one or more MET calls during an admission, how are they using that to influence, I guess, the patient goals of care and their treatment plan, and communicating that to the patient and the family? That's sort of closing the loop on everything, because often those clinical deteriorations is what families are worried about. This is the second time mum's had a fall in hospital or her blood pressure's dropped. What's causing that? And if we're using that as an opportunity to engage with the patient and their family to say, look, we believe these are the causes for it. This is what we're doing about it. I think that they're really important things. And that's something that staff, I think, should talk to when we're doing accreditation, talk about that, how we use this to learn from, look at the themes and trends, and then benefit other patients, I guess. Yep.
Awesome. Anything to add, Alanna?
I agree. I concur.
Yeah.
No, I think Kevin's nailed it. I think the biggest thing is to close it, as Kevin mentioned, closing the loop. And when something adverse does happen, what could you have done differently? So being able to learn, accreditation is also about a learning experience, learning from each other, learning what went wrong, what could we do that's different, how do we make healthcare better?
We've come a fair way with this standard, but what is the future for this standard?
I think the future is for Metro North is to make our processes and systems consistent across. We talk about a mobile workforce. We talk about people being able to move between facilities, to have consistency right across. And it will be easier once we are all digital. So it's probably, in the next 5 or so years, I think that consistency of reporting, consistency of how we do business will make life a lot easier. And I think it'll also make it easier for our workforce. So we can be a truly mobile workforce. That would be my thoughts. We're doing some great things. There's some great stuff happening out there. But I think that would be the one thing that I would love to see in the deteriorating patient standard.
Yeah, I would agree. Like using, I guess, the data we have, particularly, I guess, as it relates to MET calls. So where we have a lot of rich data there, but how we might do any data analysis, thematic analysis, particularly of the actions taken, that would be good, I think, to look at, not just beyond a ward or a hospital, but at a HHS level. I think that's where there's real opportunities. So it's where technology will be used, I think, in the future, enabled with digital solutions and IEMR and digital recording of observations to allow us to do that. Now, ICUs do that, I think, particularly well already because they've got that, but I think in the future that's where our opportunities. We do it well now, but I think that can only be enhanced in the future.